Welcome to the Skeptics Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is April 23rd, 2026, and I'm your skeptical host, Ken Milne. Title of today's podcast is I Love the Java Jive and It Loves Me, Preventing Dementia with Coffee and Tea. And our guest skeptic is Dr. Manrique Umana McDermott. He's an attending physician specializing in emergency medicine based in San Jose, Costa Rica. He has a passion for medical education and is renowned all over the world as a speaker and serves as a faculty member in the undergraduate internal medicine program and postgraduate training programs in emergency medicine, family, and community medicine at the University of Costa Rica. You can follow him on all the various socials. Welcome back to the SGEM, Manrique.
Hey, nice to be here.
Well, we should be a little bit more specific about here. We are here in Murcia. You've got to say
Murcia.
Murcia, Spain. And we are attending and participating in Incrementum 2026. Now, they often say the sequel can't possibly be as good as the original. And they started Incrementum last year, 2025. And I have to say, Paco, Carmen, and the entire Incrementum team that puts this thing on, oh yes, Incrementum Part 2, 2026, is bigger, better, and more fabulous than it was last year. Amazing. What do you think?
Absolutely, Ken. An amazing experience altogether.
And you're Spanish speaking, and 800 attendees here. Many of them are Spanish speaking. So why don't you describe it in your native language?
Pues esta ha sido una experiencia espectacular. La hemos pasado genial. Es una conferencia muy disruptiva y sin embargo se siente muy familiar entre todos los asistentes y también entre los ponentes. La simulación, la calidad de simulación ha sido espectacular y la verdad la hemos disfrutado muchísimo. Y bueno, nada mejor que estar acá en Murcia, la comida espectacular, el clima ha sido genial, la hemos pasado súper bien.
And you know how much I understood of that? Oh, that's right. A nice round number, 0, because I don't speak Spanish. But you know what I heard, Manrique? From your emotion in your voice, that it was, let's see, how can I sum this up? Pura vida?
It was pura vida.
Pura vida, yes. Well, we're not here to talk about Incrementum. We're actually doing an actual episode of the SGEM. And so why don't you give us a case?
So we have a case for that. It's a 47-year-old emergency physician who presents to the primary care physician for a rare act of preventive care between a run of night shifts. Sounds familiar?
Yes, very familiar.
She drinks 3 large coffees most workdays, switches to tea on post nights when her hands are vibrating fast enough to start an IV at 20 paces, and asks whether her caffeine habit is frying her brain or secretly protecting it. She has heard that coffee is either a miracle or a menace, or both, depending on which headline got posted on the group chat last week.
Well, Manrique, coffee, its origin story, it's like a superhero movie. The origin story reads like a case report from the annals of caffeinated discovery. Legend traces it back to Ethiopia, where a goat herder observed his animals behaving like over-caffeinated residents or trainees after nibbling at certain berries. And from there, coffee spread throughout the Arabian Peninsula, where it was first cultivated and consumed in Yemen, eventually fueling the rise of coffee houses. And by the 17th century, coffee had reached Europe, where it was alternatively praised as this miracle tonic or condemned as this suspicious stimulant. Over time, coffee became embedded in our global culture, transitioning from a mystical brew to an industrial scale commodity, and ultimately a critical adjunct in emergency medicine workflow optimization.
Oh, but Ken, in Costa Rica, we take coffee very seriously.
Yes, you do. I've been there. You do take it very seriously.
Arguably more seriously than most emergency departments take shift coffee orders. Introduced in the late 18th century, quickly became a cornerstone of the country's economy and identity. The government actively promoted coffee, even offering farmers free land to grow it, resulting in a thriving industry based on small family farms rather than large plantations. Costa Rican coffee is renowned for its high quality, thanks to ideal growing conditions, which mainly are volcanic soil, high altitude, and just enough rain to keep things interesting. The country even banned the production of low quality coffee. Today, Costa Rica is a leader in sustainable coffee production. So the next time you're powered through a night shift, there's a good chance your cognitive performance is being supported carefully cultivated beans from a hillside in Central America.
You know, Manrique, when we went and visited your beautiful country, Barb and I, we took a tour of one of your coffee plantations, and it was so interesting to see how it went from, from the farmer's field, in this case, into your coffee cup. It was a really interesting experience, and I haven't had any low quality coffee when I'm in Costa Rica. But emergency physicians, they don't need a pathophysiology lecture on caffeine. They need a fresh cup of coffee. And coffee is practically a staffing model. Well, tea is its sort of more civilized cousin, shall we say. And both have long been part of the informal pharmacopoeia of night shift survival. The real question is whether our specialty's favorite legal liquid stimulant does anything beyond keeping our differential diagnoses alive until sunrise.
Well, biologically, the hypothesis is plausible. Coffee and tea contain caffeine and other bioactive compounds, including polyphenols that might influence oxidative stress, neuroinflammation, vascular function, and insulin sensitivity. These are pathways that could plausibly matter for cognitive decline and dementia. But human studies have been inconsistent, and many older studies did not clearly distinguish between caffeinated and decaffeinated coffee.
All right, so Manrique, we're here in Murcia, Spain at Incrementum. What's the clinical question we're going to try to address on today's extra special episode?
Okay, so we're going to look at is long term intake of caffeinated coffee, decaffeinated coffee, or tea associated with incident dementia and cognitive outcomes.
Well, you've been on the show before, so you know we go through the PCOT. What was the population of the people included in this study?
Well, the population were adults and nurses, a health study, and health professionals follow-up study.
Yeah, and then they excluded people that had cancer, Parkinson's disease, they already had dementia at baseline, and those with implausible total energy intake, so maybe some emerged physicians,
Yeah.
and those missing caffeinated beverage intake data. What was the specific exposure that they were looking at?
Well, the exposure was long-term intake of caffeinated coffee, decaffeinated coffee, and tea asserted every 2 to 4 years with validated food frequency questionnaires.
And what did they compare this group to?
They compared to lower intake categories, especially the lowest quartile and tertile of consumption, depending on the beverage.
All right, let's run through the outcomes. What was their primary outcome of interest?
Okay, the primary outcome was incident dementia identified via death records and physician diagnosis.
And they had a number of secondary outcomes, and I'll list those in the show notes. What type of study was this?
It was a prospective observational cohort study.
All right, so the author's conclusions were, quote, greater consumption of caffeinated coffee and tea was associated with lower risk of dementia and moderately better cognitive function, end of quote. All right, let's go through the quality checklist for observational studies. The first question is, did the study address a clearly focused issue?
And the answer is yes. The question, population, exposures, and cognitive outcomes were clearly specified.
And did the authors use an appropriate method to answer the question they had?
That would be a yes. A prospective cohort design is appropriate for evaluating long-term exposure outcome associations when randomization is not feasible.
Yeah, sometimes you can't randomize people into like studies that go over decades. And was the cohort recruited in an acceptable way?
Actually, yes. These were Establish well-known longitudinal cohorts with repeated follow-up, though they are not representative of the general population.
Yeah, because this is nurses and other health professionals, so it wasn't the general population that they were looking at. How about the exposure that they were looking at? Was it accurately measured to minimize bias?
Well, that's another yes. Intake was measured repeatedly with validated FFQs, which is better than single baseline diet measure, but still relies on self-report.
And how about the outcome measure? Was it accurately measured to minimize bias?
It wasn't sure. Dementia Ascertain used death records and physician diagnosis with confirmation when available, but some misclassification is still possible.
And do you think the authors identified all important confounders?
Well, I'm also unsure. They adjusted for many confounders, but residual confounding is explicitly acknowledged and remains likely in an observational nutritional study.
And how about the follow-up of subjects? Was it complete enough in your opinion?
Oh, that's a yes. Follow-up extended up to 43 years, and death ascertainment was reported as greater than 98% complete, although secondary cognitive sub-studies were more limited.
Yeah, 43 years. I mean, that's older than some people listening to this show. All right. How precise are the results?
Reasonably precise for the primary outcome. The primary dementia estimate was fairly tight. Secondary cognitive effects were much smaller and less certain.
Manrique, do you believe the results that they had?
Yeah, that's a yes. I believe the association is real enough to discuss, but not strong enough to infer causality.
Okay. And do you think that the results of this study can be applied to your local population?
Yes, I think so. They're useful for counseling adults who already drink coffee or tea, but less certain in populations unlike these predominantly health professional cohorts.
And does this study fit with the results of other data out there?
Yes, they fit the biologic rationale for some prior observational literature, while also acknowledging the that earlier findings have been inconsistent.
And so we always like to know who funded the study in case there were sort of conflicts of interest. Was this study funded by Big Coffee?
It was actually funded by multiple National Institutes of Health grants.
So Big Coffee was not involved. And
No.
did the authors declare any conflicts of interest?
Actually, yes. Doctor Who reported receiving research support from the analysis group, and no other disclosures were reported.
All right, let's run through the results. In their study, they had over 131,000 middle-aged US health professionals from two different cohorts. They had the female nurses in the NHS study and then the male health professionals in the HPFS. And the mean age, like I said, was middle-aged in the late 40s, early 50s, and about 2/3 of the pooled sample were female. Now, follow-up, like I mentioned earlier, was extremely long, up to 43 years, with the median time being 37 years. Higher coffee consumers tended to be younger, drink more alcohol, smoke more, and consume more total energy. But Manrique, what was the key result?
Well, Ken, higher caffeinated coffee intake was associated with lower dementia risk.
So higher coffee intake or caffeine intake,
Mhm.
lower dementia risk. And the incidence of dementia, they gave a hazard ratio of 0.82. So that means it favored the coffee consumption. And when you looked at that 95% confidence interval around the point estimate, all of it was on the side of benefit. And so it was statistically significant. How about secondary outcomes?
Well, higher caffeinated coffee intake was associated with lower prevalence of cognitive decline, 7.8% versus 9.5%, in the highest versus lowest quartile, prevalence ratio 0.85.
Yeah, so it was about a 2% absolute difference that they noticed in the association between the highest consumers of caffeinated beverages, in this case coffee intake, and the lowest prevalence of coffee decline. And so, Manrique, let's talk nerdy.
Let's do it.
All right, got 5 points. And, the first one and the most obvious one in an observational study is going to be residual confounders. Observational cohort studies are appropriate for exposure questions, but inherently vulnerable to bias from prognostic differences between the exposed group and the unexposed group. And even after you do all this multivariant adjustments, coffee and tea drinkers may be different from the lower intake participants in some way that matters for cognition. These may include their sleep habits, their education, work pattern, health-seeking behavior, medication use, diet quality, and other unmeasured social factors. And the authors themselves acknowledge residual confounding, including neuroactive drugs not fully captured across follow-up.
And number two, reverse causation. Even in a prospective cohort, early cognitive decline could influence beverage habits and reliability of dietary self-report before a formal dementia diagnosis. Someone drifting into cognitive decline may reduce coffee intake due to sleep disturbances, jitters, GI symptoms, or caregiver influence, making coffee appear protective when declining condition changes the exposure. The authors conducted a sensitivity analysis, but still acknowledged that reverse causation cannot be fully excluded.
And that is true, yeah. The third thing we wanted to talk about in this nerdy section was the imperfect exposure measurement. They repeatedly used a validated tool, and the tool was the Food Frequency Questionnaire. That's the FFQ that you mentioned earlier in the quality checklist. And these are better than just some single baseline snapshot of someone's diet, yet they can't fully capture, brew strength. How big a cup of coffee did they go venti? How about the preparation method? How about the shift between caffeinated and decaffeinated products? Or adding things to your coffee like sugar and cream? Mismeasurement of exposure can distort observed associations. And nutrition studies are especially vulnerable because the dose is harder to standardize than if we gave someone a prescription drug, because we know exactly how much is in that prescription drug.
And the outcome ascertainment, the primary outcome relied on death records, on self reported physician diagnosis, with medical record confirmation when available. That is pragmatic and probably better in health professionals than in the general population, but it still leaves room for missed cases and misclassifications. The authors also could not isolate Alzheimer's disease specifically, which matters because all cause dementia may lump together biologically distinct conditions with different relationships to caffeine.
And the fifth and final point we wanted to bring up, Manrique, is this is time varying, confounding, and imperfect capture of exposure over time. And this basically combines my nerdy point number one with nerdy point number three. And although the authors use this repeated FFQ, beverage consumption is likely to change meaningfully over the last 30 or 40 years of follow-up. I know my consumption of beverages has changed over time, and participants may switch between caffeinated products and decaffeinated products. They might change their dose, modify their intake due to early subclinical cognitive decline. Maybe they're having sleep issues or comorbidities develop over time. You develop hypertension, and maybe the physician says, you got hypertension. Maybe you shouldn't be drinking so much caffeinated products. Even with cumulative averaging, this introduces something called time varying confounding and exposure misclassification, which represents a major threat in longitudinal observational study. If early cognitive decline leads people to reduce their caffeine, this is reverse causation, which you talked about before, onto exposed misclassification, the association could be biased in favor of appearing protective. That's enough nerdy stuff. How about we get to an SGEM bottom line?
Okay, let's do that. So the SGEM bottom line is that coffee might help your brain, but if you really want to stay sharp, don't rely just on caffeine.
Yeah, so it may help, it might help, it may not, right? This is an association. This isn't causation, which you mentioned earlier. And if you want to stay sharp mentally, physically, and stuff, you've got to do other things besides just drinking a couple of cups of coffee today. Eat a good, healthy diet, get some regular exercise, sleep, keep up your social connections, all those types of things that keep us healthy in the long term, not just one isolated thing. How about you resolve the case that we presented at the start of the show?
Okay, let's do it. So the ED physician in this case need not to panic. Switch to decaf or start prescribing espresso as a dementia prophylaxis. The best interpretation is that her current moderate caffeine coffee consumption is not something this study would lead me to discourage, provided she tolerates it and it does not worsen anxiety, palpitations, reflux, insomnia, or her blood pressure. I would frame the study as reassuring rather than prescriptive. Moderate caffeine coffee or tea intake was associated with better long term cognitive outcomes. But this does not prove that caffeine prevents dementia.
No, it doesn't. Yeah. So, how should ED doctors, because most of the people listening are ED physicians or clinicians, we've got a lot of nurses, paramedics, lab technologists, x ray techs, all these types of people that are involved in the care of emergency patients. How do you think they should apply this information clinically?
So I think ED physicians should use this study mainly for counseling, not prescribing. For adults who already drink coffee or tea and tolerate it well, this paper offers reassurance that moderate caffeine intake is not obviously harmful to cognition and maybe
Maybe.
associated with lower dementia risk. It does not justify telling non-users to start caffeine intake, nor does it support escalating intake beyond moderate levels. The advice would be to continue the coffee and enjoy, but don't confuse association with causation. Also, keep doing other healthy behaviors such as regular exercise, blood pressure control, diabetes care, smoking cessation, adequate sleep, and social and cognitive engagement, as you mentioned before.
Excellent. All right, well, let's talk about the Keener contest. Last week's winner was Robbie Allen. He knew the Kennedy risk prediction rule should not be used to identify low or high risk patients with delirium. Do you have a question for us, Manrique?
Sure, I do. So, who knows which two bean species account for the vast majority of the world's coffee production?
So if you know, you got to give me the two different species that are responsible for the vast majority of the world's coffee production. Then send an email to the sgem@gmail.com with Keener in the subject line. And the first correct answer will get a shout out on a future podcast. Well, thank you, Manrique. I mean, we have
Thank you.
we have this like packed schedule. We don't want to miss any of the speaking. Like
No, no.
we attend. We like, I go to conferences and I give a talk and stuff. And sometimes I don't actually attend and watch the rest of the conference. You don't want to miss a minute. This is such high quality speakers at this conference with great content. You don't want to miss any of them.
Not at all.
But we squeezed it in. We did.
Yeah, sure.
All right, so I've got to actually go do a talk on TXA, whether it's a wonder drug or wonder if this drug works. So can you just wrap this up with giving the SGEM tagline?
I sure can. So, everyone, remember to be skeptical of anything you learn, even if you heard it on the Skeptics Guide to Emergency Medicine.
Pura vida.